Welcome everyone to our first SIOP, or our final, SIOP CEDAR webinar. Dr. Joyce Kambugu is going to open the session and introduce everyone. Thank you so much for joining.
Hello everybody, you're very welcome to this final webinar in a series of webinars that we have been running between SIOP and IPA on childhood cancer early diagnosis and appropriate referral, CEDAR. My name is Dr. Joyce Kambugu. I am a leading pediatric oncologist in East and Central Africa with more than 10 years experience in this field. I am also the Continental President, SIOP Africa, and a very active member in the SIOP Education and Training Committee. I am based at Uganda Cancer Institute, which is the National Referral Cancer Treatment Research and Training Center in Uganda. Here I head the department or the service of pediatric oncology. I am actively engaged in the Education and Training Committee of SIOP, and also I am engaged in extending childhood cancer services to all the 4 regions of the country in Uganda. I am actively engaged in the development of the Pediatric National Cancer Control Plan. And finally, I am a very strong advocate for pediatric oncology in developing countries. The second moderator is Miss Liz Sniderman from the USA, who is a pediatric oncology nurse practitioner at Stollery Children's Hospital in Edmonton, Canada. She has worked with children with cancer for 15 years and has worked with pediatric oncology nurses, healthcare providers, patients, and families in low and middle income countries all over the world. She is a member of the SIOP Education Committee and a past co-chair of the SIOP Global Health Nursing Working Group. And finally, Dr. Michelle Farmer is a pediatrician with a public health background and subspecialty training in adolescent medicine. Michelle is a co-chair of International Pediatric Association's Strategic Advisory Group on Non-Communicable Diseases. She is an active member of the American Academy of Pediatrics, the Society of Adolescent Health and Medicine, and the International Association for Adolescent Health. She focuses on the integration of non-communicable disease, screening and prevention in primary care and community-based settings for low-resource settings. Currently, Michelle is the Chief Medical Officer for Advancing Synergy on an organization that seeks to improve prevention and control of non-communicable diseases. Very welcome my colleagues with whom I'm going to be working to moderate this session. So, the SIOP CEDAR project, in collaboration with IPA, aims to improve knowledge and understanding of general healthcare providers about the initial care of pediatric patients suspected of having cancer. This is the 7th webinar in a series of webinars, as I have mentioned before. Today, we're going to hear practical advice from oncology experts from all over the world on how we can identify children with the suspicion of Wilms tumor at the earliest possible stage. Further, we want to point out that simultaneous Spanish translation is available. And if you can look at your screen on the right bottom, you will see that icon that is colored in red, which you can press, and you will be able to access the translation immediately. I want to introduce very briefly the speakers, Dr. Amrit Kaur from India, who is going to talk to us about the case scenario, and Dr. Muhammad Ashraf from Pakistan, who will talk to us about when to suspect Wilms tumor. And finally, Dr. Vivian Painstil from Ghana, who will talk to us on approach for diagnosis, initial management, and referral. We have 3 panelists today, Dr. Hafeez Abdelhafeez, Dr. Joaquim Caetano, and Dr. Prasad Iyer, speaking or helping us to discuss. Finally, before they all come on, I wanted to mention some housekeeping instructions displayed on the screen. If you click on question at any point, you'll be able to type in your question because there's no voice option for our audience today. Text answers will come in from the experts if possible. There will be a dedicated question and answer session after the panel discussion. Lastly, we have a CME credit available for this seminar. And with that, I want to log off. Before I log off, I want to welcome the next speaker, Dr. Amrit Kaur, who is a pediatric oncology resident in Kidwai Memorial Institute of Oncology in Bangalore, India. She was a university topper at her undergraduate level and also got a distinction in pathology. She did her MD Pediatrics from PGI Chandigarh in India. Her keen interests are management of pediatric hematolymphoid and solid tumors. And she is representing the SIOP Global Health Network's Young LMIC Working Group. So with that, I want to invite her to share her screen.
Good evening, everyone. I am Dr. Amrit Kaur, resident in the Department of Pediatric Oncology at Kidwai Hospital, India. Today, I'll be presenting a case of Wilms tumor who was inadequately treated and was referred late. So this is a 3-year-old boy. 1 year prior to admission, mother had incidentally detected an abdominal lump in left side of the abdomen. However, no consultation was taken at the same time. 2 months after this, swelling had progressed and there was fever on and off for 20 days, so they had consulted a urologist. CCT abdomen was done, which was suggestive of left-sided renal mass. Child underwent left-sided nephrectomy. However, no metastatic workup was done. Post-op histology was suggestive of triphasic Wilms tumor. However, there was nothing mentioned regarding the lymph node status. Subsequently, child had received post-op chemotherapy only for 3 months and then it was stopped. And subsequently, child was kept in the follow-up. Now, after 6 months, child has been referred to our institute with reappearance of the abdominal lump and abdominal pain and cough and difficulty in breathing for last 20 days. He was born out of spontaneous conception and had birth weight of 2.9 kg. There was no history of syndromic disease or malignancy in the family. Mother and father are educated up to middle school and are unemployed. At presentation, he had tachycardia, tachypnea with room air saturation of 76% and blood pressure more than 90 percentile. In respiratory examination, he was tachypnic with bilateral intercostal and subcostal retractions. And on percussion, there was dull note over the right intra-axillary and intrascapular area and absent breath sounds over the similar area. In abdominal examination, there was 10 into 8 cm soft to firm lobulated mass lesion in left lumbar region, which was crossing the midline. Other systemic examination was normal. CCT abdomen was suggestive of large lobulated soft tissue density mass lesion in left renal fossa with non-visualization of the left kidney. CCT thorax was suggestive of 1 into 1 cm lung nodule in right upper lobe with right-sided pleural effusion suggestive of pulmonary metastasis. So this is a case of recurrent metastatic Wilms tumor who was inadequately treated. Child has been admitted to our PICU and has been started on supportive care measures. Plan is to treat as per recurrent metastatic Wilms tumor protocol with pre-op chemotherapy, followed by surgery and metastasectomy, followed by post-op chemotherapy and radiotherapy. It is very unfortunate that this case was inadequately treated and was referred late. Had he been adequately treated or referred earlier, it would have improved the overall prognosis of the child and saving the child's life. Thank you.
Thank you very much, Dr. Amrit. I'm now going to introduce our first speaker, Dr. Mohammed Shamvil Ashraf. Dr. Shamvil is serving as the Senior Pediatric Oncology Consultant and Executive Director of Medical Services at Indus Health Network in Pakistan. He's contributed vitally to establishing and enhancing pediatric oncology services in Pakistan since the 1990s in the context of infrastructure development, education and training, research and publications, national, regional, and international collaboration and capacity building. He's the founder and past president of the Pakistan Society of Pediatric Oncology. He's also the recipient of the Lifetime Achievement Award from the Pediatric Society of Pakistan Society of Pediatric Oncology, as well as the Pakistan Pediatric Association and a Dow Graduate Associate of North America. Welcome, Dr. Shamvil.
Thank you. Good afternoon. First of all, I would like to thank the organizers for giving me this opportunity to talk about when to suspect Wilms tumor in children. And the most common presentation is asymptomatic flank mass as a bulge, often noted by mother when the child is bathed or dressed, and the mass is usually confined to one side of the abdomen and does not move with respiration in contrast to splenomegaly. The child is otherwise well with no constitutional symptoms. However, there can be various other presentation of abdominal mass, particularly with the constitutional symptom. Sometimes children present with mass, which can be associated with abdominal pain, which is in about 40% of cases. And then there can be fever, anorexia, and weight loss, which can be seen in 10% of the cases. The masses can be of various sizes, particularly in low middle income countries. There can be large mass and filling the whole abdomen. It can be on one side, or it may be on the both sides of the abdomen in some cases of the bilateral disease. Blood in urine is another presentation of Wilms tumor in children. Gross hematuria occurs in about 18% of children at presentation, and microscopic hematuria is seen about 24% of patients. So any child presenting with blood in urine should be suspected for Wilms tumor and should be examined properly. Similarly, hypertension, about 25% of children have hypertension at presentation, which is attributed to the activation of the renin-angiotensin system. So any child with hypertension should be examined properly and look for the abdominal mass. And if abdominal mass is present, it can be Wilms, but sometimes it is also because of the neuroblastoma in children. The complete physical examination of any child presenting with abdominal mass is important because the Wilms tumor can be associated with other anomalies, and it is seen in about 15% of the cases. Hemihypertrophy is the most common abnormality, and any child with hemihypertrophy should be looked for abdominal mass and Wilms tumor. Aniridia is also another anomaly associated with Wilms tumor. Vagus syndrome is a combination of aniridia, ambiguous genitalia, mental retardation associated with Wilms tumor. Genitourinary anomalies can be present. It may be in various forms. Similarly, Denny-Drash syndrome is also one of the presentation of Wilms tumor. Another syndrome which can be associated with Wilms is Beckman syndrome, and we all know it is associated with umbilical hernia, hemihypertrophy, microglossia, and the children are prone to hypoglycemia. So child with Beckman syndrome should be looked for abdominal masses, and the most likely abdominal mass is Wilms tumor. Hypercalcemia is rare, but however, symptomatic hypercalcemia can sometimes be seen, but they are more common with rhabdoid tumor rather than Wilms tumor. Children with Wilms tumor or other renal malignancy may seek medical attention as a result of vascular obstruction or metastasis. including pulmonary symptoms such as those caused by the lung metastasis, as we have heard in the previous presentation, that the child presented with the breathlessness and tachypnea and other features of lung metastasis. Similarly, abdominal pain can be caused by liver metastasis, prominent abdominal wall vessels, or varicocele due to the inferior vena cava obstruction. Rapid abdominal enlargement, anemia, and severe pain may be seen in some children who develop subcapsular hemorrhage within the tumor. The most common differential on physical examination, particularly with abdominal mass in children, is neuroblastoma. And the child, however, in neuroblastoma has more constitutional symptoms. The mass is usually fixed and immobile. It crosses the midline, and metastatic lesion and symptoms are more common in neuroblastoma. However, it may not be possible to clinically totally differentiate Wilms from neuroblastoma unless we do some further labs and imaging. Thank you very much. Thank you for attention.
Thank you so much for that wonderful presentation, Dr. Shamvil. It is my pleasure now to introduce Dr. Vivian Painstil. Dr. Vivian Painstil will be our next speaker. She is a pediatric oncologist at Komfo Anokye Teaching Hospital, Kumasi, Ghana. She is also a senior lecturer at Kwame Nkrumah University of Science and Technology in the School of Medicine and Dentistry. And she is a member of SIOP, an active member of the Pediatric Society of Ghana, and a member of the steering committee for CanCare Africa, Wilms Tumor Africa Collaborative Study. She will talk with us about Wilms tumor diagnosis and management. Thank you, Dr. Vivian.
Thank you, Michelle, for that. Good afternoon, everyone, and thanks to the organizers for giving me this opportunity. I will be speaking about the diagnosis, the initial management, and then the referral of patients with Wilms tumor. To be able to make a diagnosis of Wilms tumor, you will have to take a very good history, as has been elaborated on by the previous speaker. And then you have to do your very good clinical assessment also. And then in doing your clinical assessment, you need to check the age of the patient, because we know that patients with Wilms tumor normally are of the younger age group. And so you need to check the age. Also, you need to look out for any dysmorphic features. We know that Wilms tumor is associated with some of these congenital syndromes, as has been elaborated on before. And so you will need to assess for the presence or the absence of these congenital syndromes. And then also Wilms tumor can present with an increase in blood pressure, hypertension. And so you need to check the blood pressure, plot it against the centile for the gender, and then height and age. And then check if it's high or it's normal, because it's important to intervene at that point when you have a patient who presents to you with hypertension. Also check for the body temperature or any other signs of infection, and then do your bimanual palpation to check for whether it is the mass you are feeling is a kidney mass, and also you will need to check the size of the mass also. And then in your making your diagnosis, one important thing is for you to do your investigations, your laboratory investigations, basically your blood works, your imaging, which is also very important, histological findings also when pathology is done, and then subsequently staging the disease, because the stage of the disease will determine what treatment should be given to your patients. For the laboratory investigations, a basic or a baseline complete blood count is required and is essential. Patients with Wilms tumor at times can present with polycythemia, although this is rare. This can occur even in the absence of an elevated serum erythropoietin. And those who have polycythemia normally is associated with male gender, those who are older, and those who come with a low clinical stage. So your HB is important. For some of them, some can even bleed into the mass, and so might have come in with anemia. So your hemoglobin level might be important for you at that point. And also check your platelet count, because patients with Wilms tumor can present to you with thrombocytosis, and then you will need to check for that. And then you will need your basic chemistry panel, your blood, urea, electrolytes, and creatinine, and your liver function test, and check also the serum calcium. The previous speaker spoke about hypercalcemia, and so you will need to check your serum calcium level, because if it's high, it could be an indication that it could be another diagnosis like the rhabdoid tumor of the kidney rather than a nephroblastoma. So you might need to check that your serum calcium. A small percentage of patients with Wilms tumor can also present with an acquired von Willebrand type of disease. What happens in these patients is that the nephroblastoma cells normally secrete very high levels of hyaluronic acid, which normally increases the blood viscosity, and then they bind to the von Willebrand factor, leading to reduction in your von Willebrand factor. And with that, some of the patients can bleed as a result of it. So you might need to do your coagulation profile to check whether patients have an acquired von Willebrand disease or not. And you might have to also check the urine for microscopic hematuria. And then if there are any leukocytes or nitrites are present, you can go ahead and then do your urine culture. In terms of imaging, it has been seen that improved imaging has helped to influence planned surgical resection, especially when patients are going in for partial nephrectomy in those who have the bilateral. And so in your imaging, it is recommended that if you have the facilities, MRI of the abdomen is recommended as the imaging of choice, because that gives you a lot of detail. But in its absence, you can do your CT scan of the abdomen. And then when you do your scan, you look out for the kidney mass or your renal mass. And then also you look out for a possible renal vein or inferior vena cava thrombus. And then you check for the contralateral kidney to see if the contralateral kidney is normal or there is any masses in it. And you also need to do a lymph node assessment and see if the lymph nodes are enlarged or whether there are any disease in it. And then you also have to check whether there are any liver metastasis also. With a skilled radiologist or even a skilled sonographer, an ultrasound can be used to make the diagnosis, especially in low and middle income countries where at times you might not even get your CT scan or your MRIs. And so with that, you can use the abdominal ultrasound just to make your diagnosis. To check for metastasis, your chest CT can be done to check whether there are any metastasis to the lungs or not. So if you look at this imaging here, you can see that the right kidney here is normal, but the left kidney, there is a huge mass here, which is the nephroblastoma that this patient has. And then on the CT scan of the chest, you can see these lung nodules that can be seen here. And so whenever you have a patient, because of staging, you will need to check for all these. In the absence of a CT scan of the chest, you can also do your chest radiography or chest X-ray as a baseline for pulmonary metastasis. When you are going to give drugs like doxorubicin, you would need to also check and do your echocardiogram to check the state of the heart before you give these drugs which are cardiotoxic. And also give do your GFR, especially when you're going to use the high-risk protocols which contain carboplatinum. Other tests that you can think about is the chromosomal analysis and gene mapping. That can be done in places where they are available. So if they are available in your country, you can go ahead and do those things. And you might need to analyze for loss of heterozygosity on chromosomes 1p and 16q. And normally these, when there's loss of heterozygosity, they are associated with an inferior relapse-free and overall survival. So you might need to check for that, and it helps in prognostication. So with these imaging findings, you can go ahead and start treating your patients with Wilms tumor based on the characteristic imaging findings without doing a biopsy as per the recommendations of SIOP. But there are a few cases when you will need to biopsy your patient with a suspected Wilms tumor. And these are when you have an infant coming to you with a renal mass. You might have to biopsy to see if it is really Wilms tumor or it is something else. Or when the patient coming to you is older or older than 7 years of age, you might need to go in and biopsy before you go ahead and do your treatment. Or when you do your imaging and there are atypical imaging findings like calcifications, the tumor are encasing vessels. If that happens, then you might be thinking that is that a neuroblastoma as compared to the nephroblastoma. Then you can go ahead and do your biopsy. Any other atypical features also, you can go ahead and then do your biopsy before you go on and do your treatment for such patients. So for staging of patients with Wilms tumor, there are basically 5 stages for patients with Wilms tumor. Stage 1 occurs when the tumor is limited to the kidney. One kidney, the capsule is intact. It's not breached. And then stage 2 occurs when the capsule has been breached and also limited to one kidney. And then the stage 3 occurs when there are abdominal lymph node involvement, when during surgery there is a tumor rupture, or when you do an open or a wedge tumor biopsy prior to your preoperative chemotherapy. When you do all that, that can be staged as a stage 3. When you have metastatic disease, that can be staged as a stage 4. So metastatic disease to the liver, to the lungs, and when you get lymph node enlargement outside the abdominal cavity, that can also be classified as metastatic disease, so it's a stage 4. And then your stage 5 is when you have your bilateral disease. And for the stage 5, each of the kidneys should be staged, should be sub-staged before you go ahead and then you treat the patient. So in terms of your histologic finding, the classic histologic findings for patients with Wilms tumor has the triphasic pattern. And so for the triphasic pattern, it comprises of blastemal, which can be seen in this place here with this image here. And then you can have the one which has the epithelial component, or your mesenchyme, which can be seen here, or stromal. And classically, you can find a triphasic, but at times you can have a percentage which might not be triphasic, you have a biphasic, or even just mostly there will just be one pattern in that Wilms tumor patient. And so when patients come and then there is a higher percentage of blastemal, mostly they are associated with a high-risk disease, and then treatment also, the prognosis also is not that. So after you've done your preoperative chemotherapy, at pathology, they can risk stratify it for you to tell you whether the patient has a low-risk tumor, an intermediate risk, or a high risk. patients who have the blastomal type and those who have the diffuse anaplastic type of tumor has a high-risk tumor. And then those who have the epithelial, the stromal, the mixed type, regressive, and those who have focal anaplastic type of nephroblastoma normally have an intermediate risk. And so whatever chemotherapy you are given will depend on these, whether it's a low risk or it's an intermediate or it's a high risk tumor. So in treatment, for using the SIOP approach, we normally give a pre-operative chemotherapy. Normally we give between 4 weeks to 8 weeks, depending on the stage of the disease, given either 2 drugs or 3 drugs. And with the adapted treatment guidelines, there is even an option for prolongation, especially in patients who have very huge disease. So the pre-op chemotherapy can be prolonged. After chemotherapy, there is the option for surgery. So in surgery, you do your nephrectomy for patients. In patients who have distant metastasis, there is also the chance that if there are metastases also still present after your pre-op chemotherapy, you can do a metastatectomy for those patients, also for those with distant spread. And then a few of our patients can also be given radiation after surgery. And basically, we give radiation for those who have the high-risk disease. So depending on the tumor stage, the histology, the chemotherapy response, and also the resection status, you can also give your radiation. And that is in about 15% of our patients. That is the ones that we might give radiation therapy to. And basically those with intermediate risk and then those with high risk tumors can be given radiation if it's available at your facility. And for Wilms tumor, one thing that we need to know is that prognosis is very good, even in low and middle income countries. And so we should be able to follow up our patients so that they can complete their treatment and then we can get good outcomes in our parts of the country. So as a pediatrician, it is important for you to do your initial imaging, whether it's the ultrasound that is available, it's the abdominal CT scan, or the MRI that is available. You can do that. And then make sure that your patient is stable. And after making sure your patient is stable, check the blood pressure because that is very important. If patients have a blood pressure, they can even have a seizure. So when you have, you check the BP and then it's high, you can start your antihypertensive and counsel the patients appropriately or the caregiver appropriately and refer. Make sure you discuss it or liaise with a pediatric oncology unit that is near you and then refer appropriately to the unit. Thank you very much.
Thank you so much, Dr. Painstil. We are now going to open our panel session and our Q&A. So if everyone can please remember to post all of your questions into the Q&A box. Audience members are not able to open their microphones to ask questions, so please do post them in the chat and we will direct them to our panelists. Our first panelist is Dr. Hafeez Abdelhafeez. Dr. Abdelhafeez is a pediatric oncology surgeon. He's currently serving as the Director of Global Surgical Oncology in the Department of Global Pediatric Medicine, as well as the Fellowship Program Director in the Department of Surgery at St. Jude Children's Research Hospital. He also serves as a member of the Education Committee in the International Society of Pediatric Surgical Oncology, as well as their representative to the Global Initiative for Childhood Cancer, and the Oncology Group Lead and Board Member for the Global Initiative of Children's Surgery. Welcome, Dr. Hafeez.
Thank you, Liz. I see there's really some very vital question in the chat. I will sort of start tackling some of these.
Sure, Dr. Hafeez, if you want to give us just a couple of words from the surgeon's perspective. You're our only surgeon on the panel, so we'd love to hear if you have anything to add from what our speakers had to say, and then we can have the questions answered with the panelists after, if that's all right.
Sound good? Yes, absolutely. Well, maybe I'll have a brief comment on the three phases of care for Wilms tumor: preoperative, operative, and postoperative from a surgical perspective. Obviously, the important questions comes in the preoperative phase is how will we optimize planning for Wilms tumor surgery? And I think really to optimize planning for the tumor, surgical management, a really good preoperative imaging is required. At least in the form of CT scan with contrast to delineate the anatomy of the tumor, its relationship to blood vessel, whether there is a tumor thrombus, whether there is bilaterality of the tumor. These are all very important factors that surgeon need to have all these information prior to sanction a plan of management. In terms of assessment of the chest, obviously CT scan does identify more pulmonary nodules than a chest X-ray. However, maybe a CT guided therapy or a chest X-ray guided therapy won't produce a significant difference in outcome. But yes, definitely there is more nodules identified with CT scan, and that's obviously helpful in planning. Moving a little bit to the next phase, in a limited resource setting, it does really make sense to adopt a strategy of using neoadjuvant chemotherapy before resection, and that is for multiple reasons. One of them is you have a lower risk of tumor spillage, and also that sort of approach will lead to less requirement of radiation therapy in the context where radiation therapy availability is challenging. A final point, maybe also on the operative phase, is to obviously to ensure adequate exposure, adequate incision, not to struggle with the dissection of the tumor to prevent spillage, to ensure adequate lymph node sampling and palpation and assessment of the renal vein. Plus, a final note on the postoperative phase is to ensure if the patient does require radiation therapy for a final stage of stage 3 postoperative, then to deliver the radiation therapy in a timely fashion. Thank you.
Great. Thank you so much, Dr. Hafeez. Our next panelist that we will hear from is Dr. Joaquim Caetano, Head of Pediatric Oncology Service at Santa Casa de Belo Horizonte in Brazil. He's also the Vice Coordinator of the Brazilian Renal Tumor Group and has had subspecialty training at the Graduate School of Biomedical Sciences at St. Jude's Research Hospital. Dr. Joaquim, it is our pleasure to hear from you.
Thank you, Michelle, for the kind introduction. I would like to thank all the organizers for the invitation to participate in this session. And for me, it's very fascinating to see how one case results for many topics for discussion. And I'm glad to be here to contribute with the discussion. And to stimulate more and more this phase of this presentation. When I start to think on the case presentation, 2 points come in my mind. One, regarding the early diagnosis appropriate referral. It's very important to us as a pediatrician or a general practitioner that taking care of a child, you need to think about the roots of diagnosis, the pathway of diagnosis. And Wilms tumor, it's an example how it's happened, because you can do a diagnosis by screening in patients with syndromic child. And in the case, when you talk about the diagnosis of relapse, the screening for relapse using the follow-up X-ray and ultrasound each 3 months during the 2 years after the treatment. As a tumor in the at the retroperitoneum, when this mass starts to increase, most of the time they don't provoke pain. So the first phase of diagnosis is when the child that is really asymptomatic. And as in the present case, the abdominal mass is detected by the mother or with the routine checkup with the pediatrician. And when this mass starts, very huge, it provokes symptoms. Okay, you have abdominal pain, hematuria, hypertension, and these various routes of diagnosis can reflect how the health system is working in that context. And maybe you can think about the missing opportunity to perform early diagnosis in your context. And one thing that take my attention on the case presentation is that Amrit said that the children was not immunized. So the thing that I think about these routes to diagnose and the referral pathway is that it could be the family preference to not get vaccines to their children, or maybe it could be a reflex on a huge gap on the healthcare system that imposes barriers to timeliness to diagnose. Because when you think about renal tumor, that you have a lot of children being diagnosed before age 5, and you think about the first 1,000 days of the children that require a lot of checkup, a lot of checkup of growth and immunization, you can think the missing opportunities to do that early diagnosis on that child. And finally, just not to prolong too much on this stimulating to the discussion about the treatment. I just want to remember that the Wilms tumor was one of the cancer indices that was chosen by the WHO Global Initiative on Childhood Cancer, because it is an example of the necessity of well-integrated multidisciplinary team approach. And you think about why this patient was inadequate treated, but you need to think about the root cause. And I come on the inaccurate diagnosis. How the children will perform X-ray or TC at diagnosis to detect lung metastasis. At CT, abdominal CT, there was saw some rupture, vena cava thrombus, lymphadenopathy, and of course, surgery. How many lymph nodes are sampled at the surgery? And of course, one thing that is very important that even now with the SIOP umbrella renal tumor study group guidelines, it's regarding the, if this case was discussed in a multidisciplinary team discussion, like to do a diagnostic review, it's a really stage 1, it's a really non-metastatic children. That thing that has a huge impact in how the children will be treated. So I think it's the point that I would like to stress and to get to stimulate the other discussion on that. Thank you.
Thank you very much, Dr. Joaquim, for that summary of what should ordinarily be a text. So now it's my pleasure to introduce Dr. Prasad Iyer, who is the senior consultant from the Children's Blood and Cancer Center, Women and Children's Hospital in Singapore. After completing his postgraduate MD in pediatrics in India, he went on to the United Kingdom and completed his advanced specialist training Manchester. He complemented this training with a further 4 years in pediatric and adolescent oncology and hematopoietic stem cell transplantation at the Great North Children's Hospital, Newcastle, and has since been working in Singapore for the last 9 years. He has a keen interest in precision medicine, cellular therapy, and bone marrow transplantation. He is a teaching faculty in all 3 medical schools in Singapore. His research interests involve interrogating leukemia cells for vulnerabilities that can be targeted with novel therapeutics in early phase trials. He retains a passion for all aspects of pediatric oncology and is the principal investigator or co-investigator for a few pediatric solid tumors. So I would like to welcome you to speak to us.
Thank you for the kind introduction. I think I'm sitting amongst experts, so I'll not pretend to be one. There are very, very interesting points made by my panelists. Traditionally, there has always been a different approach across the Atlantic. The American cohorts have always used upfront nephrectomy for renal tumors, and the European as well as the UK has used pre-op chemotherapy, reassessment, and then nephrectomy, and then followed by post-op chemotherapy with or without radiotherapy. So the dogma and the principles are slightly different, but what is important to know is that either approach actually, if you look at all the major studies over there, the outcomes are very, very similar. Now, if you look at some of the questions on the side, asking about whether you upstage a tumor when you do a biopsy of the tumor, I think that depends on who you ask. The Americans would always worry about that, the North American people. But the SIOP approach, especially the UK approach, has been to biopsy tumors, which you consider are slightly atypical in children who are outside of the typical age group. And they have not found any difference in outcomes, provided your multidisciplinary care, multidisciplinary setting is all set in stone. So that is the important part of it. So you need a good team of colleagues surrounding you to make sure that you're following the protocol as per plan. So the upstaging of tumor remains a theoretical risk in the right hands, and we do not recommend fine needle aspiration. We actually recommend core needle biopsy, and I can request the surgical colleague of mine, Dr. Hafeez, to say more about that and as to what. But generally, under the age of 6 months, atypical features, those are the kind of patients you would consider biopsying. The European approach actually takes a more of a radiology-driven approach, where they will not even biopsy if it is a classical Wilms based on your radiological appearance, and give them pre-op chemotherapy of 4 weeks if it is non-metastatic, and 6 weeks if it is metastatic tumor at diagnosis, and then do the nephrectomy to give you a much more guidance about it. Patients very rarely will have pre-op chemotherapy with 2 drugs or 4 drugs, depending on what they felt was, never had a biopsy, and then find very rarely that it is actually not a Wilms tumor. But even those patients, their outcomes have been quite good. So those 4 to 6 weeks of treatment actually does not change your outcomes if you go down the pre-op approach. So having trained in Europe and UK, I prefer the SIOP approach. That is what I'm used to. We don't find any particular problems in doing it, especially if you listen to the experts from Europe. They will say that, the risk of spontaneous rupture of kidney tumors is lower with the pre-op approach. Obviously, you also have the inside the body response to the chemo that you can see in your Wilms tumor when you give them chemotherapy and see if it shrinks or not. Whereas if you take it out all upfront, you won't see that. So there are pros and cons of both, but the bottom line is the outcomes are similar. But SIOP RTSG has an interesting approach. By doing the upfront chemotherapy, they've estimated that about 20% of patients will actually not need radiation, or will decrease the need for doxorubicin by their approach, by the umbrella SIOP RTSG approach. So that is another question that I will allude to, which asked about whether you need CT scan or not. We prefer to have CT scans because anything more than 3 millimeters in terms of nodule size, we classify it as metastatic disease. If the metastatic disease goes away after you give them pre-op chemotherapy, then or you get CR by surgical methods, then you perhaps don't need to give them radiation. And that is the critical point. So yes, the overall survival perhaps is not going to be very different if you just have exposure to X-ray, and you can only, because we have to remember that chest X-ray, you can only see the big-sized cannonball metastases. You won't be able to see the smaller metastases. And in the SIOP approach, we will also try to get a representative nodule during nephrectomy if the metastasis has shrunk, but it's still visible, to see if it is dead, if it is alive. So all those things matter in terms of treatment outcomes. So that is sort of quick flavor of the general philosophies behind treatment across the Atlantic, so to speak.
Well, thank you so much, Dr. Prasad. Dr. Shamvil or Dr. Joaquim, do you have any other perspectives to add on this important issue?
No, I think the approach of the Wilms tumor has been already discussed, and we at our institution and in Pakistan National Protocol for the Wilms tumor, we follow the SIOP approach because we find it more suitable for our population, where surgical expertise and other things are not at the level where we want to have more surgical complications. So giving preoperative chemotherapy is more suitable in lower middle income countries. There was one question asking that even if it is a stage 1, do you want to give preoperative chemotherapy? So it is all about what protocol you are following. If you are following SIOP approach, yes, you will give preoperative chemotherapy to all Wilms tumor. And if you are following the COC protocol, then you will have to follow according to their guidelines. So when we use a protocol, we don't do the choose and decide on individual patient. We follow the protocol. So this is actually I wanted to answer as well. And then there is since we are very short of time, so I just wanted to answer 1 or 2 questions, which was this is very important question. How do you manage Wilms tumor operated upfront based on imaging with nephrectomy without lymph node sampling? And this becomes difficult for oncologists to decide whether this is a stage 3 or it is a stage 1, because if the histology is as per the histology, it is a stage 1, but there is no lymph node sampling, then normally we treat it as a stage 3 unless the lymph node sampling is done. So we go back and see the scans and review the things, but most of the time we treat them as a stage 3 if lymph node sampling is not done. So this is important. So this is the message is that for all the Wilms tumor surgery, a proper lymph node sampling is very, very important, because otherwise it is very difficult to stage the tumor. So this is
yes, thank you so much. And Dr. Hafeez, I see you're nodding your head vigorously there. From the surgeon's perspective, as a member of the cancer care team for Wilms Tumor, do you have any thoughts that you would like to make about the surgeon's role?
Absolutely, and I wanted just to follow on the very nice point made by Dr. Muhammad, that essentially para-communication between the surgeon and the oncologist is very important to appropriately risk stratify the patient and deliver the appropriate therapy. Otherwise we'll end up with escalating therapy for somebody who doesn't need that, and obviously with all the treatment burden that comes with it, or we undertreat a patient who require more intensive chemotherapy and risk a higher relapse rate and poor and worse outcomes. So essentially, what the surgeon does in the operating room in terms of the prevention of tumor spillage and clear documentation of if there is any tumor spillage that occurred and what is the magnitude of that, whether it's localized or generalized diffuse abdominal spillage and adequate lymph node sampling. These are all very vital things that really needed to be documented, and communicated to the oncologist for the oncologist to be able to make a valid risk stratification. I may just take this opportunity and answer also a question about biopsy. Obviously, biopsy in that preoperative phase should be done only when there is features of atypical Wilms tumor, whether this is an age feature, the patient less than 6 months or older than 7 years old, there is some imaging atypical features, absence of the claw sign, vascular encasement, all these sort of imaging feature that points towards this is probably not Wilms tumor. In terms of whether a core biopsy will upstage the tumor, it won't upstage the tumor. An image-guided core biopsy, based on some few studies that are done in the field and documented no worse outcome or higher recurrence rate with core image-guided corneal biopsy. However, open biopsy does upstage the tumor. I'll stop now.
All right, thank you so much. I know that we're at time, but I see that Dr. Joaquim has his hand up. Did you want to make a quick comment and then we have to move on?
On that, I just want to do a little comment and answer one question that is on the chat, because using the thing is they ask about the horseshoe kidney. And this is exactly the case that you need to choose what to do, the preoperative chemotherapy, immediate surgery, or no. But of course, I think it's a patient with horseshoe kidney maybe should be start treatment as a bilateral, because you need to spare as much normal renal tissue as possible. So you need to reduce the size of the tumor and to proceed mainly to an nephron-sparing surgery, because this patient probably has a high risk to renal failure in the future if you start the treatment as with a primary nephrectomy. So that's my comment on that. And this case could illustrate exactly that. What to perform first, the primary nephrectomy or preoperative chemotherapy.
Thank you so much, Dr. Joaquim. I know that we're at time, and I think we've answered most of the questions, although I think there may be a few. We'll probably have to maybe post some things in another venue. Do we have time for any other additional? Oh, yes, okay. We're going to move on to our closing. Thank you so much to all the panelists.
Thank you so much to all the panelists and speakers and my co-moderators. If there's any further questions that we weren't able to answer due to time, you can go ahead and email them to Dr. Sagir Khan, who will forward them to the appropriate panelist or speaker from today. You will be emailed out the CMA credit certificate for today's session, along with the participation certificate. So that's how you'll receive that. And you can also find the IPA SIOP joint short educational videos that were done for International Childhood Cancer Day on the IPA and SIOP social media handles. You'll see some familiar faces there. There's Dr. Shantata, the president of SIOP, and they're really good, very short and informative videos. There's the QR code there. Here are the QR codes for all of the past 6 webinars. This final one will also be uploaded today on the SIOP website. You can also just go to siop-online/CEDAR to find those. As I mentioned, this is the last of our SIOP CEDAR joint webinar series with the IPA, and it's been a great success. Thank you, a huge thank you to Dr. Sagir Khan for everything he did to organize these, and the collaboration with IPA. This wouldn't have been possible without his hard work, and they've been a really great, successful project. So just a special moment to thank him. I'll turn it over to Dr. Farmer.
Yes, I also want to echo my thanks, Liz. That's very important, the relationship of SIOP and IPA to organize these webinars. Thanks to all of you participants. Your questions were wonderful, and I think that we were richly benefited from the expert panelists and speakers today, promoting early diagnosis, appropriate referral. We want to be a resource for all pediatricians. So thank you very much for your participation, and enjoy the rest of your day.